All right, so I think the aim of usually doing these updates is, I think mainly should be aimed to the fellows. And so that's why I like to present usually cases which are relevant to the local perspective. So this is a case of, as in, I'm going through a case and then I'll discuss the various things. The topic I was giving was cost effectiveness without compromising the standards. So I think this is the case aim would be to let you know the minimum amount of inventory that you should have when you're doing complex, high risk and indicated patients, which is what we call CHIP. So let's start with this case. It's a standard case indicated, and you can see that there is a calcified bifurcation lesion in the LED, and there's an occluded circ. So this is again, not all calcifications need rota, because I think only 5 to 10% of labs in Pakistan have rota, and with the mushrooming of a lot of cath labs, I don't think we need to teach other things as well. Cutting balloon, OPN, and other balloons at high pressure, long inflations also work. So we have to look at our local environment and see what we can do. So this is a calcified lesion, and in another view, you can see not only there was a lesion in there, but there was an occluded circ, and the circ does have, because it's a left type of dominant system, so there's a lot of post-occluded vessels that you can see here. So this circ also needs to be sorted out. So, so what essentially do we need for this case? As you can see that you need a special wire. Now you should have an armamentum of Gaias, which are very important, 1, 2, or 3, and you should also have a small balloon, a low profile balloon. Not all balloons are not the same. You can use a 1.25, let's say a sapphire, which is probably better than the rest of the ARTEMs, and even the FDA approved Euphora and other ones. I found that the sapphire balloons are so there are lesions where once you've crossed with the wire, you won't be able to get a balloon in. So sometimes a 1 millimeter balloon of a different make will not go in. So I think you should go for a lowest profile wire. So in this case, we used a Gaia 2 to penetrate the lesion, and then started with and managed to get a 1.25 across. So this, again, in another view, we managed to get the lesion prepared, and then, so what about the stent? So you have to have a trackable third generation open cell design, because you don't want to just put a stent in and get these vessels, and I think occlude these vessels. So I think it's important that we make excuses for vessels and occlude them after the stent and say that they are not relevant. But I think the aim for the fellows and other juniors should be, you should preserve every vessel if you can. If you can't, then you go for the vessel which you need to preserve if there's a choice to be made. But this excuse about leave, so when you start, if there's small vessel, you'd like to preserve. So once the circumflex is finished, then we need to carry on with the LED, and you can see that the LED's got a bifurcation lesion. And for these, what do you need? You need initially a double workhorse guide wire for initial dilatation. So any workhorse will do, but for these lesions initially. So then what do you need? Once you've done the thing and you've decided on a two-stent strategy, you need a third generation trackable thin strut DES, because you don't want to leave a lot of 100 micron thick double triple layers here. So essentially a thin strut is 60 to 80 micron. There are a couple of stents in the market which are 60 to 80, and in order to, and you need an appropriate length, of course. So mini crush or nano crush or whatever, but you do need this in your one trackable type of a stent. So we carry on, and then the next step that we do need to do, again in this from a local perspective, is to have an appropriate size balloons to sequentially open the size So you don't, you get a old balloon and try and open the side strut in the first case, you will not be able to. So you need that thin balloon that you used initially. That's why I used a 1.25 to at least use that balloon to open up. And then you again need a appropriate size to open up this crushed stent. So this is important. The next step is, it takes a bit of loading. So the next step is, you need appropriate size so to cross the bifurcation as opening the side stent when stent resisted. So essentially what we did was, once I opened up that thing, I couldn't get the any balloon inside into the LED. So what's happened? Because once you open the strut, sometimes the strut stuck in here. And so you need another balloon, sequential balloon. Don't worry, you've got the wire across. So you need a thin balloon, again an appropriate size to deflect that away or recrush it again. So that is where you get stuck sometimes. And so the next step again with this would be that you would need an appropriate size NC balloon to properly then crush this stent back to its original carinal position that you want. Okay, so next step is you need to deliver a stent. And in order to save the cost, you need a stent which is which you can shape accordingly, which is expandable, which is thin strut, conforms to the vessel and covers so instead of putting two stents, so you need a long stent. So this extra longest stent we have is a 40 millimeter appropriate size open cell. So you need an open cell deliverable. It should also be deliverable. So you need a long stent to save money. You need a stent which is conformables. So, and should be open cell so that you can expand it to different diameters. So let's say 2.5, 2.75 here and 3.5 here. So that is again, from that perspective, we need to understand that you need this inventory. Oops. Sorry. Okay, so the next step would be that you need to pot and you need to re-exchange and then pot. So there are two things here. You will not be able to sometimes cross with your original workhorse wire. So you need a hydrophilic guide wire sometimes to cross into the site. So if the guide wire, which is the normal workhorse, once you've exchanged, is not being able to go in, don't try too much. You can have to, and you need an appropriate size balloon to pot. So this is, in any complex high-risk indicated patient, this is the minimum kind of inventory that you do need. All right, so then after that, you do need to do the final case and you need to pot. So essentially, you need an appropriate size NC. Try and save the same NC. What I do is I reshape it again, shape it into the guide, do it an inflation of up to 2 millimeter. So that's how I rewrap the balloon. And you need a final pot with appropriate size balloon. All right, so I think, so then the final result that you will get will probably be okay, provided you've used the right inventory and different views. So you've got an open circumflex and you've got a good bifurcation stenting in this. So coming to the end of my presentation, I won't take too much time. So the next, sorry. All right. So the cost effectiveness standardization, a minimal inventory to effectively do a complex PCI should include a polymer coated and a penetrative special wire. So you need polymer coated wires as well as penetrative special wires. You need a slippery low profile 1 to 1.25 millimeter balloon. You need appropriate size NC balloons, 3.5, 3.75, 4 at least. You need 3 thin strut new generation open cell design drug-eluting stents. You need appropriate sized deliverable drug-eluting stents. And of course, you need rotablative devices or cutting balloons and covered stents in cases you are doing high-risk profile patients. So these are all that you've seen. This is the kind of an inventory that in this case we had used: the pilot wires, the Asahi, the 1.25 millimeter balloon, the Ultimaster, the long expedition. So essentially, I'm just going to take this away from here. So essentially, the cost of this procedure, the total device inventory cost in Pakistani rupees at the moment for this procedure, I calculated, excluding the drugs and disposables, the device and everything else cost around 4,75,000 rupees. So in conclusion, in the local perspective, we need to have these things. A significant proportion of PCIs in Pakistan constitute complex coronary artery disease revascularizations. And although there is no tradition of refer or defer, we tend to send these patients to bypass if we can't do it ourselves, and prefer not to send it to another colleague of us. But I think we should get into a habit of referring cases to according to their appropriate thing. If you can't do it, doesn't matter. If your lab is not well equipped, you need to go to another lab which is well equipped, or have an operator who is used to this. A minimum inventory of special equipment devices is required to successfully and effectively do a complex PCI. Cost effectiveness of such procedure depends on patient demographics. How old is he, his financial sponsorship, his comorbids, etc., and his personal paying capacity, as well as the availability of appropriate technical expertise. Thank you very much.